Our topic for today is postpartum hemorrhage. Hemorrhage is one of the most important causes of maternal mortality associated with childbearing. It poses a possible threat throughout pregnancy and is a major potential danger in the immediate postpartum period. Traditionally, postpartum hemorrhage has been defined as any blood loss from the uterus greater than 500 ml within a 24-hour period. The greatest danger of hemorrhage is in the first 24 hours because of the grossly denuded and unprotected uterine area left after detachment of the placenta. So these are the conditions that increases a woman's risk for postpartum hemorrhage. The conditions that extend the uterus beyond the average capacity, the condition that could have caused cervical or uterine lacerations, and conditions with varied placental site or attachment. Also, the conditions that leave the uterus unable to contract readily and that lead to inadequate blood coagulation can lead to a woman's risk for postpartum hemorrhage. These are the five main causes: uterine atony, lacerations, retained placental fragments, uterine inversion, and disseminated intravascular coagulation. Uterine atony or relaxation of the uterus is the most frequent cause of postpartum hemorrhage. The uterus must remain in a contracted state after birth to keep the open vessels at the placenta site from bleeding. In the event of uterine atony, the first step in controlling hemorrhage is to attempt uterine massage. First, place the client supine with her knees flexed and feet together. Put on gloves and place one hand on the abdomen just above the symphysis pubis. Place the other hand around the top of the fundus. Rotate the upper hand to massage the uterus until it is firm. When the uterus is firm, gently press the fundus between the hands using slight downward pressure against the lower hand. Observe the perineum for passage of clots and amount of bleeding. If the uterus cannot remain contracted, her physician or the nurse midwife can give intravenous infusion of oxytocin with a usual dosage of 10 to 40 units per 1000 ml of a Ringer's lactate. The woman can also be given with carboprost, metergine, and rectal misoprostol. Additional measures that can be helpful: offer a bedpan or assist the woman with ambulating to the bathroom at least every 4 hours to be certain her bladder is empty, because a full bladder pushes an uncontracted uterus into an even more uncontracted state. If a woman is experiencing respiratory distress from decreasing blood volume, administer oxygen by face mask at a rate of about 4 liters per minute. And obtain vital signs frequently, and make sure to interpret them accurately. If fundal massage and administration of oxytocin or metergine are not effective in stopping uterine bleeding, a sonogram may be done to detect possible retained placental fragments. The physician or the nurse midwife may attempt manual massage. With this procedure, the physician or the nurse midwife inserts one hand into a woman's vagina while pushing the fundus through the abdominal wall with the other hand. Blood transfusion to replace blood loss with postpartum hemorrhage may be necessary. Make certain that blood typing and cross matching were done already. Usually, therapeutic management is effective in halting bleeding. In rare instances of extreme uterine atony, embolization of pelvic and uterine vessels by angiographic technique may be successful. As a last resort, ligation of the uterine arteries or hysterectomy may be necessary. In this total unexpected outcome of childbearing, the nurse should provide comfort and support to the woman and her support person. Small lacerations or tears of the birth canal are common and may be considered normal, while large lacerations can cause complications. They occur most often with difficult or precipitate births, in primigravidas, with the birth of a large infant, and with the use of the lithotomy position or instruments. Lacerations of the cervix are usually found on the sides of the cervix. Because this is arterial bleeding, it is brighter red than the venous blood loss with uterine atony. So in repair of cervical laceration, be certain that the physician or the nurse has adequate space to work, adequate sponges and suture supplies, and a good light source. Although they are rare, lacerations can also occur in the vagina. They are easier to assess than cervical lacerations because they are easier to view. Because vaginal tissue is friable, vaginal lacerations are also hard to repair. Some oozing often occurs after repair, so the vagina may be packed to maintain pressure on the suture line. In perineal lacerations, they are divided into 4 degrees. The first degree consists of vaginal mucous membrane and skin of the perineum to the fauciae. The second degree consists of the first degree plus the fascia, levator ani muscle, and perineal body, where the third degree consists of the first, second degree, and consists of the entire perineum extending to reach the external sphincter of the rectum, while the fourth degree consists of the first, second, and third degree and includes the rectal sphincter and some of the mucous membrane of the rectum. Therapeutic management is suturing and treated as an episiotomy repair. So a diet high in fluid and stool softener may be prescribed for the first week after birth to prevent constipation and hard stools which could break the sutures. Next will be retained placental fragments. So occasionally, a placenta does not deliver its entirety, and fragments of it can be separated and are left behind. Because the portion retained keeps the uterus from contracting fully, uterine bleeding occurs. The therapeutic management is by removal of the retained placental fragment to stop the bleeding. Usually, a dilatation and curettage or D&C is performed to remove the placental fragment. In uterine inversion, it is prolapse of the fundus of the uterus through the cervix so the uterus turns inside out. This usually occurs after birth. Treatment options depend on the severity but could include reinserting the uterus by hand, abdominal surgery, or emergency hysterectomy. In subinvolution, there is incomplete return of the uterus to its pre-pregnant size and shape. It can be result from small retained placental fragment, mild endometritis, or accompanying problem with myoma. Therapeutic management is by oral administration of metergine to improve the uterine tone, and if the uterus is tended to palpate, such as in endometritis, and oral antibiotics can be prescribed. A perineal hematoma is a collection of blood in the subcutaneous layer of tissue of the perineum. Such blood collections can be caused by injury to blood vessels in the perineum during birth, so they are most likely to occur after rapid, spontaneous births and in women who have perineal varicosities. So therapeutic management is to administer a mild analgesic as ordered for pain relief, applying ice pack to prevent further bleeding. Usually, the hematoma is absorbed over the next 3 or 4 days, and if the hematoma is large when discovered or continues to increase in size, the woman may be returned to the delivery or birthing room to have the site incised and the bleeding vessels ligated under local anesthesia. So in most women, hematomas absorb over the next 6 weeks, causing no further difficulty. So let's have review questions. So when is the greatest danger of hemorrhage? So the greatest danger of hemorrhage is in the first 24 hours because of the grossly denuded and unprotected uterine area left after detachment of the placenta. And what is the first step in controlling hemorrhage? The nurse should attempt uterine massage to encourage contraction. Next question would be what is the usual dosage of oxytocin? So it is 10 to 40 units per 1000 ml of a Ringer's lactate solution. Next question would be second degree perineal lacerations include. It includes the vagina, perineal skin, fascia, levator ani muscle, and perineal body. And lastly, subinvolution is defined as it is defined as incomplete return of the uterus to its pre-pregnant size and shape. Thank you for watching.